Hey guys, Quinn Henoch here. Got another case for you. 30-year-old female powerlifter, national level. She's got two issues, both of which are only a week and a half old with no prior history. The first issue is right knee pain with squatting. The pain is medial, superior patella area. The worse it gets is a 3 or 4 out of 10. It doesn't alter her movement, and it gets better as she progresses through the workout, so it kind of warms up. An important note in her history is that she's gone from 2 days a week squatting to 3 days a week, so increased her frequency by a third. Tender to palpation in the medial joint line, but I couldn't recreate any pain or apprehension with our not so awesome orthopedic testing like Apley, Thessaly, McMurray, all the ligamentous testing for ACL, MCL, LCL. Negative for pain apprehension or laxity as far as I could tell. A bodyweight air squat did recreate the pain, but she had just trained, so it was still kind of sensitive from that. We did isometric manual resisted testing with knee extension, open chain knee extension. We did 3 sets of 45-second holds on each side at about 60 degrees of flexion, and she rated that at about an 8 RPE. Maybe slightly weaker on the affected side, but that's not terribly reliable. What was more important to me was that she was able to produce force with no giving way of the joint. She was able to push all the way through for that time period on the affected side, so that was good. We did some tempoed unilateral squatting, just a rear foot elevated split squat, 3 up, 3 down, again, just to kind of assess her load tolerance through that leg, and that actually went well. It was more comfortable than a body weight squat. She got muscle work in the quad without really recreating symptoms. I think ultimately this is going to be, at least for the right knee, it's going to be a training load management issue. It came on in close conjunction with increasing squat frequency, and so we'll manage her training load to modify and address her symptoms. It's acute, meaning that this will likely resolve on its own if we allow it to, but that may mean dropping her squatting frequency back down to 2 times a week, or maybe chopping some volume and intensity off the top end of each session. We'll just kind of have to play that by ear. She's 10 plus weeks out from her next meet, so making these types of changes in her program now shouldn't ultimately be detrimental to her comp goals. We'll probably add in some accessory unilateral work twice a week in the same form that we did in the session. Probably that split squat with some tempo just to appease the symmetry gods. She did say that she tends to favor the right side in general, and it's always been stronger and observably bigger. And one knee hurts and one doesn't, so there's some type of asymmetry there. So we'll throw that in, to maybe give the left leg a little bit of a stimulus there. Perhaps she's shifting more load onto the right side, and that's why it's symptomatic. Her second issue is bilateral hip pain with sumo deadlifting, and the pain is right in the hip crease of both sides. She is a sumo comp stance deadlifter, and important note in training history is that she's gone from 1 to 2 times a week now in sumo deadlift frequency, so she's doubled her frequency. Hip range of motion testing passively, all normal for range of motion. I could not elicit any pain at end range flexion, internal external rotation, abduction, took her all the way out to the side. All of that was fine. Active straight leg raise, 90 degrees plus on both sides. We could recreate the symptoms when she was setting up for her sumo deadlift, so we had her actually set up in her stance. And just from the eye test, her position looked pretty good. We started playing around with pelvic position from that point, doing a hard arch versus a little bit more of a posterior tilt. Still arched, but just not necessarily as much so. And we found that she was more sensitive in the hip joints with a hard arched position, and that happens to be her normal setup position relative to a little bit more of a posterior tilt or just less anterior tilt. So it's looking like a positional intolerance in her hips as well, but the conundrum for me is always, do we attempt to change her pelvic position or deem it bad, change it permanently, or do we just modify training load, or maybe a combination of both? The history is what's important to me. She started having the symptoms a week and a half ago, but her stance position and her pelvic position has been the same a lot longer than a week and a half. She's been a powerlifter a lot longer than that. So if we just automatically deem her positioning as poor, bad, dysfunctional, and try to change it permanently, we're kind of missing the big picture here. So I think we do concede that maybe a harder arch position is contributing to the joints being sensitized and doubling the training load. So what we'll do is have a talk with Coach going forward, who I have a good relationship with. We'll most likely have to modify intensities that she's lifting. I'm thinking probably pull sumo off of low blocks, and she can experiment with kind of finding a groove with her pelvic position and her arch at the bottom of her sumo stance to find a nice sweet spot where it's comfortable enough but still feels strong. So that's how we'll manage that case. Hope this is helpful for you guys. These cases go up on my YouTube channel and in the Clinical Athlete forum for further discussion.